Wonderful, one can say, morning get together, meeting, and of course, scientific talks. And we are lucky to have some audience also at this point of time. So, I think we can start our session. Our session is on oculoplastics secrets demystified. We are having very renowned oculoplastic speakers in our session, and we have tried to cover up all the important topics. So we shall be covering senile entropion and ectropion. Can I have the feed of this? ये हटाओ भाई, ये पीछे क्या रखा हुआ है? लैडर हटाओ, सीढ़ी. Yes. So, all right, we are having few more audience. So that's really encouraging. So we shall be covering senile entropion and ectropion. Dr. Anita Sethi will talk about it. Then Dr. A.K. Grover, he will talk about socket reconstruction. Dr. Honauer, we are expecting him. He is a busy man, so he'll join us for levator resection. I'll be talking about MMCR. Dr. Kasturi will talk about blepharoplasty, and Dr. Feroz will talk about enucleation and evisceration. So these all topics are, you can say, in much demand for all general ophthalmologists also. So without wasting any time, I'll invite all the speakers to come up on the dais. Dr. Anita, Dr. Grover, Dr. Kasturi, and Dr. Feroz, please come. And then, and it's my pleasure to invite now our first speaker, Dr. Anita Sethi. Sir, please come. Come up the dais. Dr. Kasturi, can you please come up? And Dr. Feroz, please come. So it's my pleasure to invite our first speaker, Dr. Anita Sethi. She is having a vast oculoplastic experience. She is an alumnus of AIMS, Dr. RP Center AIMS. She was heading Fortis for a long time, and now she is heading Max Vision, I think, ophthalmic department of Max Vision. She is a prolific surgeon, very accomplished academician. So let's hear her on senile entropion and ectropion. Dr. Anita, please.
Thank you, Dr. Mukesh, for inviting me to be a part of this wonderful IC. So I will get started. I will be talking about senile entropion and ectropion. So mainly, as the name suggests, these are due to aging changes, usually in the lower lid, and maybe unilateral or bilateral. So let's understand the anatomy of, is there a pointer? Excuse me, pointer? Okay, so let's understand the anatomy of the lower lid. The main support of the lower lid is the tarsal plate, which is not as well developed as the upper lid, but still it is a very important part of the support. And the attachment to the medial and lateral canthal tendons, which forms what we call a tarsal sling. This and the lower lid retractors are important for maintaining the position of the lower lid. The lower lid retractors are the capsulopalpebral fascia and the inferior tarsus muscle. So the aging changes are stretching, laxity of the lower lid retractors and the canthal tendons, lengthening and weakening of the lower lid retractors causes an overriding of the orbicularis muscle fibers, the preseptal over the pretarsal. Now, both the changes can cause either entropion or ectropion or both. It depends on which structure is more affected. So in the video we can see that the lateral and the medial canthal tendons are not affected. So they are in their position, and the orbicularis just rolls over this lateral tarsal sling. So entropion is the predominant part of this patient. When there is only lengthening, the lid falls away from the globe, and then you will get ectropion. And then sometimes when both the factors are there, there is laxity of the tendons and a falling away, as well as the laxity of the retractors. You will get a combination of entropion and ectropion. So coming to entropion, the main problem is the weakness of the lower lid retractors, or there is a dehiscence of the septum causing the lid margin to roll in. Managing it is temporary measures are like taping, using lubricants, and sometimes, like this lady had a spastic component just after surgery, cataract surgery, and there was a spastic component which we treated with Botox, and she was fine. But the definitive method treatment of choice is surgical. So the principles of surgical correction is that we are working on the anterior lamellar structures. We need to shorten or tighten the lax structures and strengthen the weakened retractors. There are a number of procedures that have been described. I find the modified Jones procedure the simplest and the most useful. So I'm going to describe that. We are strengthening the lower lid retractors by plicating them or reattaching them. It can be a skin or a conjunctival approach. I'm showing you currently a skin approach. So it's a subciliary incision. You dissect down to the tarsal plate, and then you dissect till you can see the dehisced aponeurosis and the retractors. Then we reattach them to the tarsal plate. So this is a double-armed suture. Through the tarsus, we are plicating the retractor and the dehisced tissues. So we pass it through the tarsal plate, pick up plicate the tissues, and then come back and make sure that it is attached to the tarsal plate. And we tighten it. The correction is seen on the table. You see the lid is turning back, and then we can do 2 more on either side. So three sutures like this, so that we get a good contour and the whole lid along its length gets corrected. There's a correction in the whole lid. Again attached to the tarsal plate and then tighten. Now in this, there is always some lax skin, so a spindle of skin needs to be removed, and depending on how much lengthening there is of the entire lid margin, you might need to either do a wedge resection laterally or a lateral strip procedure, which I'm going to show you in the next video. So in this case, after this, we had done also combined it with a lateral strip procedure. Now coming to senile ectropion, again the pathophysiology is the same, but here there is more lengthening, more laxity, and this could be medial or lateral, and it's important to see how much this person had a combination. So you do the pinch test and you do the distraction to see how much of excess lid is there, so that you can plan to correct it. In most entropion, there will be rounding of the lid margin, there's lengthening and sagging of the lid. So the lateral strip procedure, this is a very good procedure. Entropion and ectropion, and multiply, even in many other situations it is used. So you start with the canthotomy. You have to go down to the lateral tubercle. We need to attach our strip to the periosteum here, so important to go right down. Now you release, the lid is being released, so we cut the lower crust so that we can release the lid completely and then reattach it at the point that we want to reattach it. So then we split the lid margin. Now the lid margin is being split at the gray line. This is the most important step where you have to separate the anterior and the posterior lamina, because we only want the tarsal strip to so that we can lift the whole lid. So we separate the anterior and the posterior margin. And now we are fashioning a tarsal strip. So this is the tarsal strip that we are fashioning. This is another important step to remove the epithelium and the conjunctiva, because you don't want epithelium growing inside when you're burying it in the depth. So you remove the conjunctiva, you remove the epithelium. And then I'm using a 6-0 proline suture. You can use any other suture. It has to be a non-absorbable strong suture. So this, you need to get a good bite of the tarsal strip. You can do a doubled arm or as a loop as I'm doing. So it's a good, because it's quite friable, the tarsus, so you need to make sure it is large enough and the suture has been passed well so that it doesn't break away. And now this suture has to be attached to the lateral, the periosteum of the lateral tubercle. And it's important to be deep over here and make sure it is a strong bite into the periosteum. Sometimes you need to use a more curved needle. Again, one bite more to be sure through the tarsus. And then we tie it here. This is, make sure that it is lifting the whole lid, and tie a knot down and make sure it is deep. That's the important part. It has to be deep, it has to be at the correct height so that it can lift the whole lid. Then there is some, after you've tied this knot, there is some excess skin. So that excess skin needs to be trimmed. So this is, you're trimming the excess skin. Since you have shortened the lid, there will also be some skin muscle that needs to be removed.
Dr. Anita, can you please sum it up, because we have started.
To summarize, you have to study the lid changes, note the amount of laxity, lengthening, look at the state of the canthal tendons and the retractors. You can choose any surgical procedure, you can combine them. The modified Jones works very well for entropion. Sometimes you need to remove a triangular wedge as well, or combine it with a lateral canthal sling. Thank you.
Thank you. We can have one or two questions now, and then I think if time permit, we'll have a detailed panel discussion later on. So I'll ask you a question, like whenever you are doing LTS, like as you said, it can be done for both entropion as well as ectropion. So if you are doing it for entropion and in turn you are getting some entropion with LTS, so how do you manage to correct it with some modification in LTS, or any role of some sutures, augmenting sutures, if you?
Well, I do the Jones procedure first.
Along with the LTS.
I do the Jones procedure and then I do the LTS,
Okay,
so that I have turned it out and then I use
so that. So you combine both.
I can combine both.
Okay.
But More often I do the Jones and then just do a little wedge resection laterally, and that also works quite
So
well.
it's a good idea to combine these procedures. Otherwise, LTS alone may lead to some amount of entropion. The other thing which can be done is everting sutures. There are a set of people who combined LTS with everting sutures whenever it is being done for entropion. Thank you, Dr. Anita.
Or if it is mild, you may just do a lateral canthopexy rather than just sutures for tightening rather than they will also work well. If it is more, then of course we have to do an LTS.
Yeah. So when you do the wedge, when I do a wedge resection, I do that laterally, and then I just use the suture to tighten it.
So very nice, Dr. Anita. Now it's my pleasure to invite our next speaker, Dr. A.K. Grover. He does not need any introduction. He is the face of Indian oculoplasty across the world. He has been at the helm of all international societies. He is past president of APS, PRS, AIOS, and so many other societies. And he has taught a generation of oculoplastic surgeons all over. So it's our pleasure to have Dr. Grover here, and for the benefit of our panelists, we have reduced 1 minute each in each talk to compensate for the delayed start of 10 minutes. So all the panelists will speak for 8 minutes rather than 9 minutes. Thank you. Thank you for your cooperation.
Do I have it ready or should I bring my own laptop? ले आऊं अपना laptop?
Dr. Honover will join us shortly. He is busy in so many things. He is the secretary of AIOS. So I think he is dealing with Vice President visit that we shall be having later today.
Thank you, Dr. Mukesh. Thanks for this opportunity to be a part of this lovely course, so well designed, running for so many years, so popular because it deals with the basic aspects which are most important and the most important subjects in oculoplastics which are required by a general ophthalmologist are dealt with. So I'll be speaking about an anophthalmic socket, the problems associated with it. And this is a problem which has traditionally been considered a difficult area, but with simple algorithmic thinking for evaluation and management plans, it is not such a difficult area with results which are very gratifying. So when we talk about a cosmetically and functionally acceptable anophthalmic socket, we look for an adequate epithelium-lined socket, eyelids of normal length, appearance and tone, and a satisfactory implant inside the eye, inside the orbit to create the volume, a well-fitted prosthesis, absence of volume loss. So as you see here, a prosthesis which looks very much like the natural prosthesis and has a good modality. So when we talk about the abnormalities, we broadly talk about these 4 groups. There may be a lax socket or what we call an inferior phonic shelving. There may be surface abnormalities where the mucosa is not as healthy as we would have liked it to be, where there is a volume loss rather than surface loss, or there are associated eyelid conditions such as drooping or interning or ectropion, and you can further elaborate on all these and make an algorithmic plan as you go along. And we will look at them one by one. So let's first look at what a lax socket or an inferior phonic shelving implies. So when we talk about sockets, we often talk about this classical term called post-enucleation socket syndrome, which essentially implies that if you have not put in an implant following an enucleation to replace the volume, or if you placed an implant which is too small, the gravity causes the contents to shift down and forward, resulting in the inferior phonics become shelved, not deep enough to retain a prosthesis. So this is added to by the bulk of the artificial eye that you put in, which also causes the laxity to increase, and as a result you get a malpositioning and often coming out of the prosthesis. So this is the kind of appearance you get where you have the ectropion and where you have the exposed inferior fornix, and the prosthesis is tending to come out. And when you assess this, when you pull this, you see that there's enough surface. You can make a deep fornix, but it has become just shelved. So the surgical options include that we tighten the lower lid, as Dr. Anita was speaking about, or you can form inferior fornix by a closed method where you're not giving an incision by sutures, or you can combine it with an open method where you have given an incision on the lateral side, undermined conjunctiva, so that you create a raw surface which can create an adhesion when you put in those sutures. So this is how you mark the position where the fornix needs to be past these sutures, which you need surgical needles, big needles, which will take a bite through the periorbita and the periosteum and will recreate this fornix. So this is the closed method. And in the open method, I would normally just give a lateral incision, undermine right here, right up to the tarsus here, right up to the inferior orbital rim here, so that I have that raw area. When we pass my sutures through this, they would cause an adhesion, and these sutures need to remain in for a couple of weeks, and they provide very satisfactory, gratifying results. Now let's look at the surface anomalies, which is the second group, and contracted socket is one of them with its various classifications, and associated abnormalities such as granulations, implant exposure, papillary reaction discharge, and fibrous bands. So this is all that you need to look at. You need to particularly concentrate on the fornices and particularly on the inferior fornix. You may have various kinds of surface problems. Let's first look at the associated problems like conjunctival cysts, which form at time, granulation tissues form like this cyst you can see here, or granulation tissue like this, which forms because of chronic irritation, or you may have a granuloma associated with an exposed implant, which may need to be tackled with removal and graft. You may have these kind of fibrous bands, and they all need to be tackled. If there are localized bands without too much surface problem, you can deal with them by various techniques such as Z-plasties, as we have done here, and caused this fibrous band to not dent our superior fornix. So this is what has been done, and combined with a lateral tarsus strip for tightening. Now let's look at the contracted socket part, which is one of the major problems. It's been graded mild, moderate, and severe, and we know various reasons. If there are surgical problems or if there have been preoperative scarring, those are the causes for early contraction, and late contraction occurs because of inflammations like meibomian gland disease, like implant that has not been placed, or an implant that is irritating, and so on and so forth. So mild socket contractions can be tackled often by taking care of the lash entropy and modifying the prosthesis. But if there is a moderate contracted socket where inferior, superior, or both fornices show contraction, with inferior fornix being the more important one, with resultant poor motility, non-closure, enophthalmos, and so on, these may require various measures. And prosthetic modifications do sometimes help, but often you need a surgery for these. And the grafting is the one that has given the most satisfying results. I prefer the lip mucosa with a significant excess and fornix formation at the same time. So this is how you work. You give an incision, usually in the center, unless there is a central eyeball or a central implant, and then you can do a good undermining up to the bony margin to create the area where the band will form, adhesion will form, and you take mucosa, take the mucosa and put it in, it should be adequate, and at the end you should put in your conformer or your volume expander so that the graft can remain in position, and it usually results in very gratifying results. And you get a good motility. Amniotic membrane graft has been suggested, but is possibly not such a good option, because it is, after all, only a substrate and not a substitute graft, and it would work for minor problems only. Severe contractures may be very difficult to tackle, especially post-radiotherapy ones, especially dry sockets with epidermis like this, where you can sometimes get away with split skin grafting like this, and where we have managed to give her some kind of a prosthesis, and she's undergone a couple of surgeries later to take care of the lateral canthus. Now, volume loss is the other major problem, and this is where you either need augmentation, or if there is a surface problem as well, then dermis-fat graft is a good option. So, a decreased orbital volume may occur because you placed a small implant, or atrophy, or gravity that we have spoken about. And here, when you have this is a dermis-fat graft that you take from the lateral aspect of the hip in an area which is not dependent, which you don't need for sitting. You need to make sure that you take just the right volume of fat, and you use a good closure of this side and do a good closure here, and you can get very good results. Can be a good option in children where it's supposed to grow as well as the child grows. And associated eyelid conditions like ptosis and entropy and ectropy also need to be taken care of. So you assess them like any other ptosis, but very often you need you may need a levator tightening or even suspension. So, and ectropions we've already spoken about. The LTS procedure is often the first choice, but there are other options like replacing the prosthesis with a smaller prosthesis. Lash margin entropion can be taken care of by the standard procedures. So this is how you assess and manage. You need to do a good assessment to see whether it's just a shelving, whether there is a surface problem like granulation, implant exposure extrusion, surface losses, volume loss, eyelid problems. Implant-related problems we'll be talking about in another course. We have another course on anophthalmic socket day after tomorrow. Or is it tomorrow? Tomorrow. We have another course on anophthalmic sockets tomorrow, and I would invite all those who are interested to come in there for a detailed description only of an ophthalmic socket. So with an appropriate evaluation, an algorithmic approach to assessment and planning and choice of procedures, most cases can be helped to achieve a reasonable cosmesis for a good psychological rehabilitation, and we know how important it is for a person to have an aesthetic appearance for his confidence, for his ability to face the world. Thank you very much, and thank you, Mukesh, again. Thank you.
As always, sir, lovely, comprehensive. Just wanted to ask you, patients have received EBRT, and they come with a very avascular and very badly contracted socket. So any suggestions for that?
Hello. Those are the tough ones because they tend to fibrose a lot. So it's best to maybe try the conservative measures where you can. If not, go ahead with the mucous membrane grafting unless it's grossly contracted and has become a slit. Then as I showed, you can use an epidermal graft, a dry socket. But otherwise, a mucous membrane graft can be used with ample precautions, maybe use of some mitomycin C in the post-operative period, and pray to God that fibrosis doesn't spoil all that you have done.
Thank you, sir. Like you have very rightly mentioned about the use of good amount of, like we take buccal mucosa in such situation because we need a larger chunk of mucous membrane. But another option is if you can have some pedicle flap along with the blood vessel. So in such situations, sir, I usually take a temporalis flap, and this can either be covered with the amniotic membrane. Along with it, now too I use PRF in all my procedures, and also skin graft. Only thing that when the child undergoes a radiation, there is not only a contracture of the soft tissue, there is contracture of the bone also. So that bony component is very difficult to manage. So many a times you might have to do some surgery in the maxilla and try to rotate it so that you get a deeper socket, and then you fill with a temporalis flap. I've been doing this, and sir, on 4th, tomorrow, right? We have a course on retinoblastoma. So there will be showing in enucleated socket how can we manage like those with bad contractures.
So as for the bony
Yes.
contracture, as Dr. Kasturi was pointing out, the most important is prevention. So when you have an enucleation at a younger age, you must replace volume. There were earlier questions about whether an implant is placed in a post-enucleation socket or not. But now with the availability of imaging techniques, there is no longer the risk of the tumor recurrence being masked by an implant. So an implant is invariably used so that the bony socket can grow. Because if you get a bony socket which is small, then the problem becomes much more difficult.
Thank you, sir. That was an excellent presentation. I call upon Dr. Mukesh Sharma, who is the present Chairman Scientific Committee of Oculoplastics Association of India. A great, I should say, a very great surgeon, a great academician, and also he was the past president of Jaipur Ophthalmological Society, and also he's the organizing secretary of AIOC 2026. So we are very thankful, Dr. Mukesh, for having this wonderful session, and also look forward to your talk.
Thank you, Dr. Kasturi, for the kind words. So today I shall be speaking on MMCR, and I have no financial disclosures to make. We shall be having Dr. Santosh Honawar shortly. He is busy with some administrative work here. He is General Secretary of AIOS, so he will be talking on levator resection. So when we talk about posterior lamellar approach ptosis surgeries, there are various procedures available. Fasanella servate is one, Muller's muscle conjunctival resection, which I will be talking, is the other one, and posterior approach levator procedures are some other procedures. But MMCR stands out, and this is the procedure of choice for posterior lamellar approaches nowadays. Generally, these approaches are preserved for mild to moderate ptosis. In any case of mild to moderate ptosis where we want to contemplate this, we do first phenylephrine test. If it is positive, it means Muller's muscle is functional and MMCR would be successful. Then we take a patient for MMCR. If it is negative, then we'll have to go for other surgeries like Fasanella servate or maybe levator resection. So how to do a phenylephrine test? We all know about it, but still we instill 2 drops of phenylephrine drop, and after 5 minutes we check for MRD1. If there is rise in MRD1 of 1.5 millimeter or greater, it means Muller's muscle is viable and MMCR will be successful. There are various nomograms which are suggested for MMCR. Dressner has given one which is quite popular. Here what he suggested is that 4 mm resection should be done for 1 millimeter of ptosis, 6 mm for 1.5 millimeter, 8 mm for 2 millimeter, 10 mm for 3 millimeter, and maybe 11 to 12 mm for more than 3 also. He has suggested that MMCR can be done for more than 3 millimeter of ptosis. And if phenylephrine test is little less, suppose only 1 millimeter of phenylephrine test is positive, then additional tarsus resection may be also included. And then Paris has given his own nomogram. What we are following is this: we have done some modification based on our own experience. So we do, these things are almost same, but tarsus resection we are doing in conjunction with this nomogram, and we resect up to 2 millimeter of tarsus in MMCR, 1 millimeter for additional 0.5 mm of ptosis. So these are the steps of MMCR. We'll see these steps in video. So this particular patient was, I think, 6 years old, and its surgery was done under general anesthesia. So lid is everted on a Demers retractor. You can see the tarsus line, lower margin of tarsus, and we are marking 4 millimeter from this. So we intend to resect 8 millimeter. If you want to resect 8 millimeter, because tissue are folded here, so you mark at 4 millimeter. These mark are deepened by diathermy, and it gives you hemostasis also. Then we are passing 3 stay sutures, silk sutures. You can use any suture thread also. These are just to hold. And then this intervening tissue is pulled up. You have to pull these sutures towards ceiling so that this tissue is being tented up, and you can apply your clamp very easily. So once you have grasped the intervening tissue, you apply your diathermy ahead of this, so that after cutting this tissue, bleeding will be less, and then we pass a running suture. So we are using 5-O-proline here, 6-O-proline, sorry, and we pass it in a shoelace manner. It has been entered in through the skin, then we have reached onto the conjunctival surface, and with the help of this clamp, this suture is passed in all this width of lid. So we have passed it, and this suture has to be around 2 millimeter away from the metal margin, so that you don't cut the suture while cutting the tissue. So once you have reached onto the next end, you come out again in the skin. Now you just pull on to this clamp, so the tissue are taut, and with metal to metal contact, you cut the clamp tissue by the help of this knife, BP handle knife. So once you have resected the tissue, I have included around 1 millimeter of tarsus also, because the ptosis was around 3 millimeter in this particular patient. Then you can unfold the tissue and measure how much you have resected. So this is folded tissue, 4 millimeter. Now just for our own interest, we will unfold it and measure the unfolded tissue. So this will be double the amount of measurement which you have made. So it was 4 millimeter. So this intervening tissue is 8 millimeter. So once you are done with this, you tighten these two ends, place a knot, and after 8 days or so, you just cut it here and pull out this suture. So it's a very neat surgery, bleed very less, post-op morbidity, swelling and all, they are very less. Patient recovers very fast, wonderful results actually. So MMCR, I believe it's the first choice for most cases of mild to moderate ptosis, of course with good levator function, and phenylephrine test has to be positive. The other advantage is that it is fairly predictable. It gives you very good cosmetic outcome without any skin scar, without any other significant complication. Learning curve is not significant. There may be some disadvantages. You can have fornicial conjunctival shortening if you are doing it too much, like if you are resecting around 10 millimeter or maybe more than that. But nowadays, instead of resecting more, we resect some amount of tarsus. This shortening may be of some value if you want to contemplate glaucoma surgery later on. And of course, in severe ptosis, you have to have some additional measures. So to conclude, there are various approaches available for posterior lamellar ptosis surgery, but MMCR is simple, predictable, and relatively complication-free surgery. Thank you. Thank you for your patience hearing.
Thank you, Dr. Mukesh. I think that was beautifully presented, very practical manner in which everybody can do it. Now, the advantage of this procedure, as Dr. Mukesh said, was ask any one of them, they sleep very well on the day they do it. When they do a levator procedure, they are waiting to see the next morning how the patient has behaved and whether the lid is where they want it, or is it higher or is it lower, but not with this. So you sleep very well. So wherever there is a choice, do this procedure, because if you have aponeurotic ptosis, which has a good levator action, which you diagnose, as he explained, with a distant lid fold and thinning above the tarsus, which you can feel, and your phenylephrine test is positive, you can do this procedure and relax. Predictability is excellent and very few side effects, if any.
So now it's my pleasure to invite Dr. Kasturi. Dr. Kasturi is the current president of Asia Pacific Society of Reconstructive and Plastic Surgery. So I think it's indeed a matter of great honor for us to be here sitting with one past president of Asia Pacific Society and one current president of Asia Pacific Society of Reconstructive and Oculoplastic Surgery. She is an excellent teacher and a very, one can say, a thorough oculoplastic surgeon. We always tend to learn things from her presentations, at least me. So we look forward for your talk, Dr. Kasturi.
Thank you, Dr. Mukesh, for having me in the course and also for the kind words. You let me know when to stop. I'll just, because it's a very basic course, I'd like to go slow.
We'll have to do 8-minute talk only.
Yeah.
Actually.
Yeah, once it is 8, so no financial disclosure. So whenever we think of doing blepharoplasty, especially for the upper lids, we should know some difference between the Asian and the non-Asian eyelid. Definitely in terms of the lid crease, where we see the non-Asian, like Indians have a much beautiful lid crease as compared to the Asian eyelids. Then the tarsal plate height. The tarsal plate height for the Asian, that is especially for those from the Southeast Asian countries, it is much smaller as compared to the Asian height, tarsal height. And the third difference we see, the fat is more in the Asian eyelid as compared to the Indian or to the non-Asian eyelid. Then there is always an epicanthal fold in most of the Asian eyelid. And the most important, if you look to the skin texture, you will find that the skin of the Asian eyelids are much thicker as compared to the non-Asian. So considering all these important points, we should plan how do we go ahead for the blepharoplasty. And for the upper lid, it is a small, very simple surgery where variable amount of the eyelid skin, the orbicularis oculi muscle and the orbital fat, these are being either excised or redraped or sculpted in order to bring a very rejuvenated eyelid. So this word blepharoplasty has come from the word blepharon, which itself means the eyelids, and the plasticos means to mold. Today it is one of the most time-tested surgery, having both functional and cosmetic indication. Functional because I have already mentioned that the Asian eyelids, we have the lateral ptosis, lash ptosis. Because of the lash ptosis, it keeps on touching the cornea, and this causes the release of all the inflammatory mediators, especially the MMP9 and other cytokines, and this inflammation leads to the increased osmolarity, and then the tear production decreases. So this vicious cycle keeps on going. So this is a very common indication why we prefer doing a upper lid blepharoplasty, and which has already been reported by us. And this is where you can see the eyelashes being redirected, as you can see this before and after the procedure. So this is what I have seen, especially in the northeastern part of India. This creation of this lid fold, lid crease, along with the redirection of the eyelashes, really helps him to prevent many of the corneal complication. Second important indication is aesthetic. Aesthetic, where we want to have a beautiful lid crease with a good tarsal plate height. So when I talk of blepharoplasty, there are different ways of doing upper. It can be a mini, it can be standard, it can be only muscle excision or extended blepharoplasty, or can be a skin excision with or without fat redripping. And all of these depends on the type of the surgery, how much amount the skin, muscle or the fat are being excised. So mini is something which is very nice to be done, which is something like MMCR for ptosis surgery, where you just need to give small 2 incision, expose the LPS after incising the orbital septum, and then you need to give the sutures. This is how we do a mini blepharoplasty. Like you can see, there's asymmetry, and she has a very small, the lid crease. So you give 2-step incision, then you expose the orbital septum, incise the orbital septum, and you should be sure that you have incised. Take out some of the post-septal fat, and then you put a suture, skin, orbicularis, LPS, skin, orbicularis, skin. So there are different ways. If you take a bite in the tarsus, you will give a very static crease. But if you just take the bite of the aponeurosis, the chance of static crease is not there, and it gives a much natural dynamic crease. So this is what we want, especially in the small children, small girls, where the only indication is to have a small beautiful lid crease, and this is one of the most common indication of surgery, and they feel so good. Like this is one of the doctor for whom I have done, and the next day or after a few days she had sent this, then ma'am, I feel that this lid surgery has boosted my confidence. So this is what a small surgery can really bring about a big change. But what is a standard blepharoplasty? Here you need to excise some amount of the skin or muscle and the fat, depending upon how much amount of the fat distribution is in the upper lip. So this is just after the skin excision, then you can see the orbicular is being excised, then you incise the orbital septum, and then you can see the two fat pad, the medial and the central. So upper lid, we know there are two fat pad, and you decide how much amount of this fat you want to remove, or you don't want to remove, or you want to go for redraping, and then you go for lid crease formation. Here I am going for static formation because I am taking a bite on this on the tarsus. And this is what exactly you can see. This and the crease is so very prominent, and it is so static, and this is basically required by the Indian people who do not have the lid crease, and not in the other Southeast Asian country, where they, which I call the Indian blepharoplasty or Bharatiya blepharoplasty, whatever you see, because they want a good lid crease, they want a static lid crease, and not even then they want a good tarsal plate height, so that the even if you apply the eye makeup, it is seen much better. So now what we see that today nowadays there are multiple cases of blepharospasm, and especially for the apex of the lid opening. In such situation, it is what we call a muscle blepharoplasty, where you need to remove most of the protectors of the lid. And when I say of the protectors of the lid, it not only includes the orbicularis, it includes the corrugator, it also includes the procedures. So after removing very small amount of the skin, it is mainly concentrated to the orbicularis excision along with some parts of the corrugator and the procedures. You need to go up to the fronto-orbicularis interdigitation, and then you should be very sure that you are actually removing the corrugators. And but you have to be very careful. Just below the corrugator we have the superior ophthalmic vein. So you should see and excise. Can you see? This is a superior ophthalmic vein. So you should see and excise, and then once you excise, I am going little fast. Go for the same procedure in the lower lid, and this is how you have excised most of the patient, most of the muscle. And what you can see, the patients really feel that the quality of life is improved. As you can see, this lady, you can see how she was before the operation, and this is after. Sometimes you need to give Botox also only to the frontal part but not to the other part, and she feels that what she has mentioned, that she feels that now she is a much better woman or a new woman. But what I mean to say that along with this, whatever tissue you excise, you need to have the eyebrow in the correct position. So always do a eyebrow fixation, which can be a internal browpexy, and this is the traditional way of internal browpexy. But what I believe nowadays, that to have a more permanent result, I do something which we'll do for a scleral fixated IOL surgery, like the 4-point fixation. So what is this? This I call, this is one of the innovative way that I have started, which is I call the guiding technique. So I take a 4-row Prolene suture, and I make 2 fixation on the either side, making a 4 fixation. You don't need to take the suture out, you just glide it along the roof and also the suborbicularis tissue, and then you fix it to the periosteum. Go just below the periosteum, and then you fix it there. So this is a very nice way of doing a internal fixation. Sometimes you have patient like this, where you need to do more extent with blepharoplasty, where along with the removing of the skin, removing of the muscle, what you need to remove is that you need to remove even the roof. So this is a roof that I have removed, and once you remove the roof, the same thing, you have to keep the eyebrow in the correct position. That is the refixation of the eyebrow, and you can see that it really helps them functionally. How it helps them? By increasing the temporal field of vision, by
Dr.
also
Kasturi, please
decreasing
sum up.
the astigmatism and also the high order aberration. So with this, I would like to conclude. Thank you very much for the patient hearing.
Wonderful presentation, Dr. Kasturi. Like, we can have 1 or 2 questions or a comment from panelists.
Yeah, you're right, Mukesh. We always learn something from Kasturi. I really like the way you did the brow pexy.
Yeah.
That's excellent. So really wonderful.
This really works. Initially when like we say that it does not stay brow plexi, but after doing the 4-point fixation,
Yeah.
I have seen it really stays up.
Yeah, and I think that's important to highlight. It's not just the lid. We are looking at the cosmesis of the upper part of the face. So the lids are a very important part. The eyebrow is a very important part of that. So, addressing it all together, excellent.
Actually, I also wanted to share the same thing which Dr. Anita has said. It's really very good the way you have done this bropexy.
In the national symposium that Feroz has organized, so I'll speaking beyond blepharoplasty. So I'll be showing some different ways of how to do the brow, how to do the mid face, and some amount of facelift when we do a low blepharoplasty. When
Really
we
good.
have it, that is on last day,
Last
6th.
day,
Yeah.
All right. So now it's our pleasure to have Dr. Feroz. She will be speaking today on entropion and ectropion. Evisceration and enucleation. Yeah, I correct myself on it. Dr. Feroz represents us on the in the scientific committee of AIOS. She is the member scientific committee. She is based in Bangalore, and also she is an international oculoplastic surgeon. She goes regularly to Dubai, I think, Dr. Feroz? Yes. Dubai, I think twice a month, and she does surgeries there also. She is in a significant demand all over. Yeah,
Dr. Mukesh is very, very kind. One, very kind for the introduction, and also very kind of you to have me in this course. Yeah. So, well, as Dr. Grover said, this course has been running for many, many years. And how is it very popular is because we talk about very basic things for the general ophthalmologist and what you do in your practice, and it also suits for the specialist with intermediate, making it an intermediate course of giving information. And what I like about this course is it's mainly surgical. So what Dr. Mukesh has given me the responsibility today is one of the most easiest oculoplastic procedure. And well, let me take a show of hands. How many of you do evisceration and enucleation in your practice? Well, how many of you do blepharoplasties? Okay. All right. So yes, the show of hands is the same. Right. So, right. This is my affiliation and few of that which has been mentioned by Dr. Mukesh, my financial disclosures. Now, Dr. Ashok Grover has already showed you regarding the contracted socket. So I'm actually a line before the contracted socket, This is how you avoid a contracted socket and the aftermath of the cosmesis, a cosmetic blemish that you create in a patient. Now, losing an eye and sight itself it's a huge trauma for a patient. So it is our responsibility, not just as an oculoplastic surgeon, even a general ophthalmologist who get to see these patients regularly in your practice, to give them volume replacement. No evisceration, no enucleation should be done without an implant. Although the patient might look good with the prosthesis initially, but in due course of time, at some point, they're going to land up with a contracted socket. Now, so losing an eye, and this is how, we finally land up with a near-natural cosmesis. Near-natural cosmesis is with a good surface and also a volume. This is a retinoblastoma child. You can barely make out that the child has lost his left eye. Well, simple, straightforward. I'll keep it completely video-based here. We all know the indication of enucleation, intraocular tumors. A, intraocular tumors, B, intraocular tumors, C. So whenever there is no evidence or a history which indicates to a trauma or anything which is going wrong in a painful blind eye, you should always ensure that there is no tumor lurking inside that eyeball before you do an evisceration. If it's doubtful, enucleation is the treatment of choice. And of course, phthisis bulbi, which is very, very severe, and then trauma with a severe globe rupture where you cannot actually salvage the sclera, then you go for an enucleation and microphthalmia. The principles of surgery is very, very direct, straightforward meticulous dissection, volume restoration, muscle attachment for the motility, and 3-layered closure to avoid exposure and extrusion of the implant, whichever implant that you have kept inside, and obviously a customized ocular prosthesis. I'm just going to take you through this video of enucleation. This is what I do regularly in my practice. It is the minimal manipulation myoconjunctival technique. This is a case of retinoblastoma. So especially in intraocular tumors, it's very, very important to do an indirect ophthalmoscope and make sure that you as a surgeon mark the eye, which eye you're going to enucleate, especially when a child is with bilateral retinoblastoma. So this is a 360-degree conjunctival peritomy, which is very, very neatly, nicely done. Salvaging the conjunctiva is important because that is ultimately going to be your surface. So save it as much as possible. This is the tenons which is getting separated with a tenotomy, blunt tip scissors, all the 4 quadrants in between the muscles, and then you identify the muscle. This is a simple muscle hook, that is the medial rectus. Be very gentle with these tissues. This is a traction suture which I 100% use in retinoblastoma and intraocular tumors because that gives me a traction. I'll show you that step later. And this is the tack suture of the muscle. So we go step by step. Now this is the inferior rectus, then we go for the lateral rectus, and then we go for the superior rectus. That's a superior oblique where we don't tag it, but we just cut it. Similar way, this is the inferior oblique. We don't tag it, but we just cut it. It's a very thick muscular vascular muscle, so we often use cautery to do it. Now this is where the traction suture helps me. There's a small conjunctival opening in a small baby socket. This traction with the black silk gives me a long optic nerve stump, and that is my aim in enucleation in a case with retinoblastoma. I need a long optic nerve over here. I target for at least 15 millimeters, so the traction helps me. Then I cut the optic nerve. In fact, if there is any scleral thinning, you mark it and then you send it to the pathologist. So well, that is what how the removal of the globe is. Formalin, I'm not going into it. So this is a PMMA implant which is kept posterior to the posterior tenons. And then this is the posterior tenons that I'm closing here, the posterior fascia. And then the muscles are attached to the respective fornices, medial to the medial fornix, inferior to the inferior, lateral to the lateral, and superior to the superior fornix. And after attaching all the muscles, that's the inferior, you take a thick bite, juicy bite of the anterior tenons, and the anterior tenons is closed. And after the anterior tenons is closed, the conjunctiva is closed with a continuous buried suture. So that is about enucleation. Well, movement with enucleation, this is again a retinoblastoma child. Very good movement with the PMMA implant intact there, and that is after the prosthetic eye. Well, there are situations where we land up with complicated enucleations as well. There's a child with an optic nerve glioma who was not treated, unfortunately, initially. There's a large optic nerve glioma sitting in the parents. She is almost blind in the other eye because it's bilateral glioma. The parents were concerned about the cosmesis, and this is a humongous tumor along with the enucleation which was taken care. Since the parents were concerned about the cosmesis, yes, cosmesis rehabilitation was done in this patient. Now, again, certain complicated situation where it's a step-by-step approach in a microphthalmia. Initially, it's a surface expansion with prosthetic eye, customized ocular prosthesis. It's a very microphthalmic eye inside. I got this child in my hand at 2 months of age, and then this is 3.5 years after an enucleation has been done. So I go it in a stepwise manner. Unfortunately, there are situations where we land up with bilateral enucleation as well. Evisceration, contraindication. More than indication, I want to talk about contraindication, which I emphasized. Intraocular tumors and phthisis bulbi severe. Ultrasound B scan is a must. before you go for an evisceration to know exactly what you're scooping out. A quick surgery on evisceration. There are different techniques. 4-petal is talked a lot about. I don't do it in my practice because I've seen migration of implant in 4 petals if it is not closed well. So I find 2 petals very, very safe. So yeah, this is what I'm going to show you here. This was a painful blind eye in a post-trauma patient. So he had undergone multiple surgeries initially. There is a little bit of scarring in the conjunctiva. Peritomy step is the same. Tenotomy step is the same. Well, we give a stab incision at the limbus, and then the cornea is corneal button is removed. It's the same. It's nothing special here. Well, what I do in order to scoop out the uveal contents, because I want it really neatly, nicely out, I use a periosteal elevator initially to separate the ciliary body where it's really adherent, and then after I make sure that 360-degree the ciliary body adherence is cleared, then only I go out and use the evisceration spoon, because I don't like piecemeal extraction of the uveal tissue. I really love taking the whole thing out. And then, well, cleaning of it, I cauterize. Then this is the alcohol, absolute alcohol cleaning of the scleral tissue in order to destroy any of the uveal pigments which is residual in the sclera. Make sure the the area is dry and the alcohol doesn't spill when you are cleaning with the saline. I almost use 20 ml saline to clean it. And this is the 2-petal. I go in between the 2 recti in different quadrants, opposite quadrants, inferior and superior. I get a nice petal over there where I can put a big implant. This is actually a 20 millimeter implant which it could accommodate. Neatly go inside and then cover the sclera, then the tenons and the conjunctiva. That's a scleral closure, very relaxed closure. That's the conjunctival closure. And well,
Dr. Kasturi, please
evisceration
sum
is
it up.
easy. Yeah. So this is how he looks after. That's the moment. We're done. Thank you so much. And yeah, I acknowledge my ocularist deeply, extremely, who gives a wonderful prosthesis for me after enucleation and evisceration. Thank you.
Thank you, Dr. Feroz. We can have 1 or 2 quick questions because we started, I think, 15 minutes late, but still we are able to hand over you, I think, bang on time, I can say.
But one thing I must say, Feroz is the most popular of all oculoplastic surgeons. She's had a big audience, including cornea surgeons.
Including cornea. Thank you, Dr. Mukesh, for keeping my talk at the end. The sandwich time, yeah. Thank you. How many cornea surgeons does evisceration after a corneal ulcer? Extremely few.
We treat them. They treat them well.
Therapeutic PK.
Of course. No, but if you land up in a situation where it's like bad corneal ulcer and you have to eviscerate with a panophthalmitis, you do it or you send it to an oculoplastic surgeon?
Give it to our residents.
Okay. Agree.
Avoid kar diya.
Agree.
Rajesh, you can say कभी-कभी भेज देते हो, it's okay.
आप बेचते हो कि आप करते हो?
सवाल
That's
को
all.
The
evade,
question is
सवाल
very
को
direct.
evade कर रहा है.
If you want, I can definitely say that yes, we do send to our
But you also do it?
No, no, no.
No, we don't.
Never. The cornea never does it. Your fellows, no one does it. Yeah. Okay. Okay. Just the question.
Rotated in the oculoplastics also.
Yeah.
They do it there.
Okay. Okay. All
But
right.
Feroz, the point that you made about the evisceration seems like a very easy surgery. I know it's the first surgery you get as a
Yes,
resident.
yes.
But to get the good cosmesis, what
Yeah.
you highlighted about making the flaps, I think that is really important.
Yes.
Whether you do a 4-petal or a 2-petal, very, very important to make sure you have adequately covered the implant well so that
And
there's
a
no
good
extrusion.
volume implant, because sometimes when you don't make a flap, you compromise on the size of the implant, and although you're giving an implant, you're actually not restoring the volume. So this gives you, helps you to put a bigger implant here. And finally, a good outcome. Thank you so much. Thanks for your patient listening. Thank you, Konya guys, being here.
Thank you. So this brings us to the end of our session. I am really thankful to all our fellow panelists for having such a wonderful session and the precious audience at this hour, 8 a.m. on the first day. Thanks a lot, everyone.
Thanks to our wonderful chief instructor for a really well-planned course and a wonderful content. Thank you.
Thank you, Dr. Mukesh.